So thank you for the opportunity. We're going to talk about the current concepts in management of knee osteoarthritis. We'll start by letting you know about Professor Marcel Levi. He's a physician by trade, but he is an epidemiologist and a researcher. I'm sure clinicians around on this meeting would know about him. He did speak to us last year at our British Orthopedic Association about the top 10 interventions that have had the largest impact on sustained quality of life. And right now, this goes along amongst the Western orthopedic surgeons because of all the backlog of elective work following COVID. And they keep reminding themselves the reason why they end up doing joint replacement surgeries. And you can see the list there. And most of us are offering wonderful services around at Maroof. Rabes, these participants that are coming in, do I need to keep clicking on them to admit them? Or can I just carry on with...
You just carry on with your presentation, sir.
Right. Okay. Right. Thank you. Thank you. So reconstructive orthopedic surgery or joint replacement is #1 on the top 10. So we try to offer a certain quality of life with joint replacement surgery. So knee arthritis, osteoarthritis particularly, we won't be talking about rheumatoid arthritis. It's a degenerative disease of the knee joint that causes progressive loss of the articular cartilage. Incidence, to be honest, is about 1 in 5, certainly in my practice, as well as the Western Hemisphere. But I'd like to put in some local research. And from Karachi, they've found that per 100,000, there are 88 people, they end up coming to them with knee osteoarthritis. And that's about 240 per 100,000. I think it may be a little bit underrepresented, but that is the research that we've got right now from locally. Risk factors, there are some that we tell our patients that it is possible for them to lengthen the inevitable process. And there are some that we don't have any control on. So the modifiable ones are where if somebody's had an injury to the knee joint itself, post-trauma arthritis is something which is very tricky, and the reasons why we fix fractures around and about the joints is to prevent arthritis. Repetitive knee bending is something that in carpet layers, bricklayers, manual workers who squat, lift things, we've seen that this is a risk factor. Muscle weakness, where the joint doesn't have the muscles and the ligaments to support them, and they knock in an aberrant manner and cause repetitive trauma. Large body mass, and I'd add metabolic syndromes to it, where we found that central or truncal obesity with high glycerides, high blood pressure, and fasting glucose has been related, has been shown to be worsening the knee arthritis. Non-modifiable factors, this is something that we found that females are more prone to having knee osteoarthritis, not just in Pakistan, but elsewhere on the planet as well. With further increase, there is wear and tear. Genetics is something that I do mention to my patients, and race. So sadly, we are part of that cohort where Asians, whites, and Hispanics end up having more joint replacements as compared to the African Americans. Apologies for the busy slide, but generally what we're talking about is what goes on in osteoarthritis. So if we look at the cartilage, the cartilage starts swelling up. The proteoglycans, which are the essential nutrients within the joint that provide all the nutrition and eventually the integrity of the joint is altered. There is eventually reduced amount of proteoglycans. I keep telling my patients that after a certain age, the amount of proteoglycans that were made in our body is all that we've got, and they start depleting. In common terms, I'm talking about glucosamine, chondroitin sulfate, hyaluronic acid. Collagen, type 1, type 2 collagen end up changing into scar tissue. 3, the organization and orientation of that cartilage is lost. The lining of the joint has lots of inflammatory changes, and that's why sometimes when we end up suggesting to give them anti-inflammatories or a steroid shot, we're trying to reduce the inflammation around the synovium to improve the pain, which eventually changes into increased thick and vascular, and that's when anti-inflammatories stop working. The bone just behind the articular cartilage starts remodeling. I tell my patients that whatever you do to bone, you break it, hit it, infect it, spit on it, it changes into making more but abnormal bone. And that's what ends up happening in arthritis. Again, fairly technical, but bottom line, the proteolytic enzymes end up start chewing the articular cartilage, starts digesting them. And we found that with immunohistochemistry, that there are quite a lot of inflammatory mediators, TNF-alpha, interleukins, that end up getting secreted more. Genetics, this is something that I do keep mentioning to patients, that this is non-Mendelian. So in simpler words, I keep telling them that you are born with this, this gene that causes you to have arthritis. You may not have had it from your parents, and you may not give it to your children. But conversely, they need to realize that it does run in families. Researchers at Mayo are still working very hard to try to link it to genes like the vitamin D, estrogen, and other inflammatory cytokines. A little bit too technical for me. I've had a read and I keep following them, and I'll wait till we've got something a little bit more robust before I start offering anything otherwise to patients in my consultations. Classification, generally the joint starts narrowing, the bone starts behaving abnormally, and osteophytes are made. The sclerosis or the subchondral bone starts thickening up and whitened up till the end, where there is no joint left, and they start having a bone deformity, which is generally either in a fixed flexion variety, varus, or valgus. Presentation, we end up having patients specifically who are in their 5th or 6th decade. They were reasonably active, and then suddenly something gave and their activity has started dropping. They also start mentioning that their pain has now come in their backs, their thumbs, their shoulders, and we end up thinking that their arthritis has started playing up. They keep talking that their function is now limited. They can't go to the mosque. They can't go visit their friends. Their family members walk a lot quicker, and it's very hard for them to catch up, apart from other knee stiffness, swelling, and instability. But the one thing that gauges the severity of their symptoms is nighttime pain, because if they can manage the daytime with some pain medicines, but at nighttime, if they toss and turn in bed and if the knee wakes them up, then that is quite severe, because the following day is quite bad, and they end up getting into that vicious circle, and that's where we need to try and help them. Physical examination, like we said about the modifiable factors, we do look at the body, the body habitus. We do, as soon as sometimes if we have a busy clinic, I do come out of the clinic just to watch them walk before we sit them down. And we end up finding is what we call a specific varus thrust. And if you could look in the picture, an A, he walks straight, but as soon as he lands his knee wobbles and gives way to the outside. And that's because of the ligaments that have imbalanced, the joint space that is narrowed down, and then he eventually returns back to his original. And just by looking at their gait and then confirming with history and examination, we end up really narrowing it down to the arthritis of the knee. Imaging, X-rays. I would, to all clinicians, please do not request an MRI on anybody over the age of 60, because the MRI would end up showing that they've got wear and tear, inflammation of the joints with wear and tear of the meniscus, clinically correlate. I think anything under 50, yes, there's a role of MRI, but what you're looking at is X-rays. And what we're looking on x-rays is joint space narrowing, again, osteophytic changes, subdermal sclerosis, and sometimes we end up seeing spicules of gout, which represents either phosphate or pyrophosphate arthropathy. There are some optional views. If you can remember, getting the sunrise view and a PA view in 30 degrees of flexion or a notch view, it will be helpful for us in clinic, and it saves time. Non-operative treatment, we've got strong evidence for non-steroidal anti-inflammatories and tramadol, and we found that we've got a good 2 to 3 months of improvement in pain and stiffness over placebo with these medications. But increasingly important, and this is something that I routinely do, and if you get a chance with your patients who say that, yes, I've got breathing problems, but my knee hurts, and if they can start with rehabilitation, physiotherapy, wellness, looking after their weight, diet and low impact walking and aerobic exercises, there's really strong evidence that we can prolong the inevitable arthritis. Moderate evidence, acupuncture. If people come back with acupuncture and they ask me, I say I have very little evidence to support that, and I do tend to back out from it. Viscoelastic joints, the UK and the National Health Service has stopped funding these, and because they've ended up finding that there's no benefit with viscoelastic substances. Glucosamine chondroitin sulfate, again, has got moderate evidence, but the evidence does suggest that if you do give them glucosamine and chondroitin sulfate, the need for non-steroidal anti-inflammatory lessens. So in my practice, I don't give anti-inflammatories for more than a couple of weeks, but I carry on with glucosamine and chondroitin sulfate for a little bit longer, just in the hope to provide some nutrition and the proteoglycans that have been lost. Needle lavage, there is ample evidence that if we carry on sticking needles into joints where they don't need to be, there's a high chance of developing septic arthritis. Lateral wedge insoles, some people like them, some people say it ends up hurting their heel, but the baseline in that is actually that somebody with knee arthritis may have some ankle malalignment, but that needs to be addressed as a separate matter. There's now increasing evidence of PRP, PRP in layman terms, but it is autologous chondrocyte plasma in a specific way that's been used. The various randomized controlled trials which have shown that it is safe, that's to start with because it's their own blood, and up to 12 months of symptomatic benefit. And in younger patients, certainly in my practice, anybody under the age of 55 with wear and tear, I do offer them PRP. And in this hospital for the last 3 years, I've yet to repeat an injection because we're keeping keeping an eye on patients that we've injected on. I do have a very stringent and a strict criteria to whom I'm injecting PRP in. Operative treatment, high tibial osteotomy is where we're trying to offload the wear and tear from one compartment to the other. I limit these to very few, and this is a lady who's 34 and she's a widow. She's got 4 children and teaches in Sawat. And she's got this arthritis, and everybody said that she's got to live with it. And it becomes increasingly difficult to offer somebody to live with this for the next 70 years. So we ended up doing a high tibial osteotomy, which is offloading the pressure from the medial joint to the outside. And you can see that we've broken it down and pushed it the other way. And this is about 7 months later. And she is now walking. She is, looking after her children. She is earning her own livelihood, and that gap is slowly filling up. It takes about 14 months for it to fill up. We've done a few of these at Maruf for a very strict, a niche group of patients, and they seem to be doing reasonably well. Now, how do I move on to operative treatment? So the other option then is that if they've got an isolated compartment that is worn out, you can do half a knee replacement or uni knee replacement. Proponents of this say that it gives excellent results. Research certainly and joint registries across the planet have shown that they do have a higher revision rate because they end up having arthritis in the other compartments. And certainly in a socialist environment, that may work really well, where you can revise them very quickly to a joint replacement. But at a place where patients are paying on their own, I would probably offer them either an offloading type of surgery, such as a tibial osteotomy, or move on to a joint replacement. Total knee arthroplasty or joint replacement is where, you know, we've exhausted all non-operative options, and they end up having, you know, severely worn out knees, affecting their quality of life, including sleep. And the one question that I ask them is, do you think you can carry on with your life with this pain? And if the answer is yes, we hang fire and we carry on with non-operative route. But if they say no, then that means they're ready for a joint replacement surgery. Joint registry that I tend to follow, and I've been practicing, and we've been using the same implants at Maruf that we were using for the last 15 years. So the joint registry that we've got reports about 15 years. And bottom line, mostly females. The younger they are, you're looking at a slightly higher revision rate. But what you're looking at is the cohort of patients that we end up operating on. There's a 95 to 97% chance that their knee will carry on surviving for the next 15 years. And that is what I tend to offer and tell my patients. This is the summary of 100,000, more than 100,000 joint replacements done in the UK. And that has been a 4% rise from 2015 to 2016. We found that more than half of the patients have been females. Their average ages have been, you know, close to 70, a similar age group as to what we are doing it. 99% have been osteoarthritis, and the others may have been post-traumatic or rheumatoid arthritis. And primarily out of these 100,000, 94% of the surgeries have been for primary procedures. And if you notice that increasingly in the UK, and certainly in my practice, I'm doing these procedures on heavier patients, because previously they used to say that you need to reduce weight before we can offer joint replacement, but patients get stuck into this vicious circle of not exercising because of pain, gaining weight, and then it hurting them more. Finally, we've got the newsletter this time around. We've got a patient's journey from the time that she was seen in clinic all the way down to about 6 weeks to 6 months in our Maruf newsletter. I'd urge you to read it. And if there were any patients interested in knowing about what happens in the knee replacement, it will certainly be helpful for them. And with that, I thank you and open to any questions. Thank you.
Thank you, Dr. Bali. I have a question. How many times
thank you so much. Can I go ahead, please?
Yeah. So, how many times would you repeat PRP on a younger patient before eventually thinking that you have to go on to a surgical treatment if it's not helping the patient?
Yeah. So I think so. The data suggests that you're looking at. So what I need to look at is I'm going to offer them a big surgery. This is the major most surgery that you can offer somebody as far as orthopedics is concerned, amongst others. So I want to delay it as much as I can. So the magic number is 60 plus. The thing with PRP is it's their own blood. The only two side effects are that it may be expensive for them and it may not work. So yes, I can repeat them however many times they want in order to try and prolong the inevitable, which is knee replacement. Now there are a few where it's come back so bad that even after PRP and they're I've not had it to date, but certainly with steroid injections, I've had people who say that this has gotten worse and it's gone rapidly bad. And what options do you have? And if we've counseled them, then yes, we can move on to step 2, which is knee replacement surgery. I would probably offer them as many times as they want till they reach that, an arbitrary magic number of 60. Because from there onwards, I know for the next 15 years, I've got ample time to, give with confidence, tell them and offer them the longevity. And in time, it may be that these joints are working on for longer and longer. But for now, if I've got 15 years of evidence, I want to take them to that 60, 65 mark and try to manage them non-operatively as long as I can. It doesn't necessarily happen every time, but certainly that's my counseling with them.
Yeah, thank you.
Can I have a comment?
Yeah, please do.
Yeah, thank you so much, Mustafa. And you'll probably notice that all those who suffer from this are online at this point today, and not just because of a personal interest, but also because, mashallah, you do a great job presenting. So I just wanted to know, is there any impact of a certain kind of footwear on taking, let's say, some pressure off the knee? And do you recommend any particular kind of footwear? I'm not talking about brand, but talking about footwear which can so to speak take the pressure off the knee in patients with osteoarthritis of the knee.
Thank you. That's an excellent question. There is so much work being done right now into the fact that if somebody's had a knee replacement and it's not working out very well for them, so people have started moving down to the foot and ankle. And some have actually realized that there was some malalignment of the foot and ankle that has made the knee arthritis worse to start with, and the same biomechanics are making things worse for the knee replacement that's done. So yes, bottom line, the heel needs to be looked from the back and worked out whether the heel is drifting inwards, that is varus, or the heel is drifting outwards, which is valgus. And we need a neutral, heel neutral insole. Most of the insoles over the counter are medial arch support insoles for people with fallen arches. And if we do get medial arch in supports, it does try to bring the fallen arch back, inevitably the valgus or the outward heel back into neutral alignment as well. So rather than so footwear, it's very difficult because now they've made it they've got specific ones for running, they've got specific ones for squash, specific for football, and so on. So an insole inside the shoe may be a far better option. Custom made would be ideal for somebody to make a tailor neutral or a heel neutral orthosis to keep the ankle aligned so that it offloads any wear and tear on the knee. I've been wearing insoles for unrelated reasons since 2003. Seem to help my knee.
Fantastic. So, because you notice Imran Tahir is going strong, mashallah, and he wears those pink shoes. I'm sure that it has some insoles or specific of orthotic device in there.
Absolutely.
Thank you so much.
Absolutely.
Thank you.
Right. If there's no more, thank you for your time and the opportunity.